start with Cameron Henzman.
Can you hear me okay? Thank you everyone for coming. My name is Cameron Henzman. I'm a pre-medical student, second-year graduate student, and senior laboratory technician at the University of Kentucky in Lexington. A lot of us are aware of the subacute stroke population and mild to moderate stroke and the recoveries and the rehabilitation techniques that are used in that population and how they've been effective or not effective. What I want to talk about with you all today is the chronic, so post 12 months from the stroke, and the severely affected population and how those people can recover and continue to improve years and years after their injury or years and years after their stroke. The people who come in for our presentation present usually in a wheelchair and with a mild to moderate to assist needing the transfer from the wheelchair to the robotic training device, and their arms are usually very tight as well. So what do we do with these patients? It's been shown in the literature that recovery post-stroke, neuronal plasticity or functional reorganization of the brain is vital to their success. In the subacute population, what we've seen is that that can be enhanced using an intervention technique called peripheral nerve stimulation. Some people may be familiar with it, some of you may not. The general idea is we place stimulating electrodes that can be seen here on this patient right here, and they are sending trains of pulses to the brain on the nerves, so the patient will hear, like, feel a tap, 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 tap sensation, or they may not, depending on how intense the stimulation is. And that's one of the questions we were interested in our study, is how much stimulation is appropriate for this population. Do we want to give them a high stimulation, a loud tap, 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 or something that's quieter? Tap, 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 tap. What's better for the brain? What is more useful for reorganization? So the previous studies in the subacute population only evaluated at the lower intensity of the soft tap, 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 tap to the brain, and they did it only before training. So what we decided to do was take the chronic population with the severely affected, not just the mild to moderate affected, and see how this different pairing of the stimulation at a high tap, 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 or a low tap, 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 before they received training or during their training, what was the best result? Patients came in and they were evaluated at a baseline using behavioral outcomes of the Fugel-Meyer assessment scale, the stroke impact scale, and a transcranial magnetic stimulation was used to measure cortical reorganization. So that's how we were able to measure neuronal plasticity from the beginning of the study to the end of the study, and I'll talk more about that in a minute. So we have 5 different groups. Patients were randomly assigned into one of these different groups. The evaluators, the trainers, the trainer was myself in all cases, and the patient were all blind to which of these 5 groups that they were placed in. So a patient would come in for 10 consecutive days, 10 consecutive weekdays, and they would be stimulated, and then they'd be placed either, depending on the group, they would either be stimulated before or during the robotic training. So let's look at a couple of these figures. Right here we see a patient who is on our robotic device and in motion too, and the patient has the electrodes placed here on the radial nerve. We also targeted Erb's point in the neck and the median nerve in the elbow to try to work with, in the Erb's, the deltoid muscle, the radial nerve on the triceps, and the median nerve of the biceps. Those were the muscles we were training. So a person during this intensive training would sit at the robot device here, and they would move their arm, which was slightly constrained, not constrained in use therapy, but their arm was constrained in this device. And as they would move their arm, the computer screen would respond. So they would be asked to move this dot that they control up and back, and they go through a series of 960 movements a day for 10 consecutive weekdays. After each set of 80 responses, the patient would get a small report card, and I would use that report card to determine the progress and how challenging or not challenging I would make the movements for them. But each patient would do as many as they could, not to exceed 960 per day. Down here what we see is well, let's talk again about this picture. You also see monitoring electrodes. This allowed the stimulator person to make sure that the patient was receiving the correct amount of stimulation throughout the study. Moving down here we see an evaluator and a subject undergoing transcranial magnetic stimulation. And what the evaluator here is holding is a coil. The patient is wearing on her head a tracker device that is also on the coil, and it allows us to have a co-registration between the patient and this computer software system that we see up here, which is a BrainSight 2 from Rogue Research in Canada. That allows us to place a virtual grid over the patient's head that corresponds to the EEG 1020 system, And so what we can do then, as the evaluator, I can move the coil from spot to spot on the patient's head. And we have monitoring electrodes placed on our target muscle, which in this computer screen we see the motor evoked potentials, MEPs, which is essentially a muscle response that is elicited by the transcranial magnetic stimulation. So the way this works is I'm holding the coil and it goes, makes a big tap, tap on the patient's head, and we will see a response in the target muscle. So depending on where I'm placing the coil, we'll see a response in the corresponding muscles. What we're interested in there is going from spot to spot to see what parts of the brain give us responses in our target muscles. With the stroke patients, and especially in the severely affected ones, on the ipsilesional side, we didn't see many maps at all, which is common for that population. However, we mapped the contralesional side as well to see how changes affect in neuroplasticity. Does the contralesional side change, and how does that correlate to behavioral measures? That was something we were interested in. So this is a TMS. This was what we performed at baseline.